I don't have any disclosures. So can basic science help? Will basic science enable us to get rid of tapes with something better? And I was going to start by making a joke, maybe we should call it Trexit. But after the last 24 hours, it's not quite as funny as it used to be, so I decided not to make that joke. So can basic science help? Well, it can't solve the problem, but there are some promising bits of evidence. And the two main things I'm going to talk about are what's our understanding of mesh complications, how has it developed recently, and the understanding of how implanted materials act, how the body integrates them, how the body produces inflammation, and what's the risk of infection in those has developed. And then I'm going to talk about how regenerative medicine or bioengineering may be able to help in the future. We're not there yet, but there's some interesting developments that I'm going to talk to you about briefly. And bioengineering involves an underlying scaffold, seeding the material with cells, and then using biological manipulation to produce an artificial tissue which can then be implanted. So just to recap, what type of materials have we used for incontinence surgery? Well, the commonest is rectus fascia, as in the rectus fascia sling that's already been talked about. Allografts have been used, but they're not very successful. They have infective risks and long-term failure rates. Xenografts the same. And finally, there's synthetic meshes. And synthetic meshes have been developed really from the development of hernia mesh over several years. And after trial and error and finding that several meshes cause fibrosis and also cause erosion, we've worked out that the best type of mesh has pores which are bigger than 75 micromillimeters, monofilament, and typically are polypropylene. But polypropylene isn't ideal. What is the ideal mesh? Well, first of all, it would have a low infective risk. It would be incorporated into body tissues with some inflammation because you do need remodeling of tissues and tissue ingrowth, but not much inflammation. And it would also need to retain its long-term strength. I think the other thing to say about a long-term material, particularly with mesh, is that there should be an acceptable low risk of long-term adverse events, particularly after removal. We know that after removal, 30 to 50% of patients have ongoing problems after mesh removal. Obviously, incontinence can then be retreated, but particularly with pain, that may be a long-term ongoing problem. So why was mesh developed? Well, the rectus fascia sling operation does have a good long-term outcome with a low failure rate and a relatively low complication rate. But the abdominal incision is unpleasant and patients don't like it. So when it was suggested that polypropylene mesh could be used, the initial results showed a low failure rate, and it's still got a low failure rate and a low complication rate. But if you've got a 3% complication rate and you put in 100,000, that's 3,000 patients who are going to have a problem. And I think this is when it became an issue. So that's why mesh was developed, to avoid the donor site morbidity. But now we realise that even though the complication rate is low, it's significant. In other words, there's no ideal implanted material for treating stress incontinence at present. So what causes mesh problems? Well, there's erosion, pain and infection. More controversial are the systemic symptoms that some patients complain about. Is it related to some absorption of the mesh in some way? We don't really understand. But the mesh problems are probably multifactorial. There's probably some patient problems, patients who are smokers, who are obese, who have diabetes, all will have increased risks of mesh-related problems. The material isn't ideal, and I'll talk about that in a minute. And then finally, there's the technique. We also know from experimental studies that if you implant mesh into the abdomen, it behaves in a different way to if you implant it in the vagina. So what have we learned about the tissue reaction to polypropylene? It is the best mesh that we've got, but it's still not ideal. We know that if you look at the histology after a mesh is being removed, that type M1 macrophages are increased compared to type M2. Now, inflammation causes a macrophage response. Type 1 macrophages are related to inflammation and aren't what we want. We want patients to have ingrowth of tissue and remodeling. We know that higher weight of mesh and mesh with smaller pores tends to have an increase in M1 type macrophages, so inflammatory response. We also know that when vaginal mesh has been explantated, there are an increase in type M1 macrophages, so something perhaps is going on. How does infection occur? Well, bacteria adheres to the mesh, there's proliferation and a biofilm formation, and by then it's probably not possible to treat the infection with antibiotics. You then get chronic inflammation, and certainly in breast implants you then get capsular contraction. That's been well studied, and possibly the same thing may happen in meshes. A recent theory is that we may have problems with the small proportion of mesh that cause problems because of asymptomatic infections. We certainly know that some meshes do get infected, and that may be clear. One study looked at 175 of meshes which have been removed, finding that even in those where there's no erosion, up to 77% will have a positive culture, and of those, a third will have pathological bacteria. In addition, 100 meshes which have been removed were also looked at. Not all of these were erosions. And the histology showed similar appearance to abscess formation or chronic inflammation with macrophages and giant cells, suggesting that there may have been an underlying infective procedure going on. So how can basic science help? Well, you could look at the current materials and modify them. And there have been nanomolecules of silver added to polypropylene mesh to try and reduce the infective risk, and also antibiotic integration. So polypropylene can be soaked in antibiotics before implanting, but it doesn't adhere very well. Another approach, which I'm going to explore a bit more now, is bioengineering. And that's developing new techniques with scaffolds, which can be either artificial or derived from animal tissue, adding cells, and then chemical or physical additives. So I'm talking about regenerative medicine, which is using a combination of scaffolds, cells, and other compounds to create tissues which then function. This is one way of performing bioengineering. So you take a biopsy from the patient, you then isolate the cells, and we first did this for oral mucosa. So we took oral mucosa biopsies, we isolated fibroblasts and keratinocytes, expanded them, added them to a scaffold. We used dermis originally, and then with mechanical and bioactive factors, you get tissue development. And we initially used this to implant in patients with urethral strictures in 2005. That seemed to work, but there were problems with fibrosis. So then we said, well, what do we need to know? Is the scaffold the problem? What's the best scaffold material? What are the best cell types? We use fibroblasts, could we use stem cells? How do scaffolds react to strain? Particularly if you're going to use it in pelvic organ prolapse, where it's going to be mobile and under tension. Does it respond by producing more fibrosis, or does it produce elastin and collagen? What's the acute inflammatory reaction? And how well is it integrated into the tissue in the long term? Does it avoid fibrosis? And finally, how well do the tissues around it remodel? So these are the questions. And here is a few of the answers that we've developed in Sheffield over the years. So first of all, we looked into what type of engineered mesh is the best. And you can see we looked at cadaveric dervis, small intestine, polypropylene, and electrospun polylactic acid. And we looked at various aspects. We tested these for cell viability, cell attachment, collagen production, elastin production, and tensile properties. And the bottom line is that the two best were electrospun polylactic acid or porcine small intestine submucosa. And I'm just going to flick through these, but basically all of these were looked at. And out of all of these, the electrospun polylactic acid was the best. And as it's an artificial material and there's no risk to infection because it's not derived from any animals, that was the one that was chosen. It's biocompatible, it's biodegradable, and it avoids concerns with animal tissues, as I mentioned. And this is how you make it. So you can see a voltage, there's a syringe pump with the polymer in the syringe, and there's a drum which rotates at the end. And as you rotate the drum with electronic current, you eventually get a mesh. And if you look at this under the electron microscope, you can see that there are microfiber scaffolds with small pores. So we thought that this was a good mesh material. So then you have to seed it with cells. Initially, because we were using oral mucosa, we used oral mucosa biopsy as a source of cells. But other stem cells can be used. And an easily accessible route is adipose-derived stem cells, which can be taken fairly easily via percutaneous biopsy. So we compared the two, and certainly adipose-derived stem cells do attach to PLA. They produce collagen after 2 weeks. And here you can see some immunofluorescence which shows that they're nicely adherent, producing collagen fibers. So, tissue engineering, you need cells, and we found adipose-derived stem cells seem to be the best. You need a biomaterial or scaffold, and polylactic acid seemed to be the best of those that we chose. Next, you need to use cytokines or growth factors so that when the tissue is incorporated, it behaves as functional tissue. And eventually you want a tissue substrate, and then the other important factor is how it remodels in the animal or human that it's implanted in. So we've done further work. Some animal studies have looked at polylactic acid scaffold with or without cells, and we found that when you look at it after 3 to 7 days, that with cells is integrated better with less of an inflammatory reaction. We've also looked at dynamic loading. That's really with a view to the possibility of using it for pelvic organ prolapse. Obviously the pelvic floor moves around a lot more than a hernia repair, so it has to respond in an appropriate way. So we've done this by growing these scaffolding cells on a balloon and blowing the balloon up and letting it down over time. And we found that elastin is produced by doing this, which is what will be required. We've also produced polylactic acid with chemical release, vitamin C and estrogen, and we found that when used in animal models, estrogen increases angiogenesis and collagen production, which would always also be necessary. So in summary, we do have a better understanding of mesh complications. There seems to be an abnormal host reaction, possibly related to a subclinical infection. Bioengineered tissue is a new option. It's been trialled as artificial oral mucosa. It's not better than the patient's own oral mucosa, but it can be used. Polylactic acid scaffolds and adipose-related stem cells seem to be promising. Biologically active molecules such as estrogen may also be helpful. But at the moment, if you had a choice between rectus fascia from a patient themselves or bioengineered tissue, you certainly want to use rectus fascia, but it does have the additional comorbidity of harvest. So take-home messages. There's still no perfect sling material available. Complications are probably multifactorial related to the patient, the material, and the technique. But mesh-related factors, or tape-related factors, and possible solutions are becoming clearer. Tissue engineering looks promising, and it may have some applications in the future. It's still early stages. We need more animal studies and appropriate models. Probably the sheep is the right one. And then long-term clinical evaluation before it can be used in place of other types of mesh. Some acknowledgements, thanks to Chris Chaplin, Sheila McNeil and all of the research fellows over the years for their help with the slides and information. information. Thank you very much.